I never heard anything else.
The Institute of Medicine may have finally said something I agree with. They said too much of the resident training money was going to Massachusetts, New York, and New Jersey.
They said that?
Yeah.
It was obviously somebody from Hopkins.
Or at least that's what I've interpreted. They want $50 to get a copy of that report, as I interpret the data.
Oh, really?
And I've tried this before. I've tried to see if online I could pull up one of their reports. I never could. Have you ever tried that?
I've never tried to do that. They sure caused a lot of trouble.
I agree.
Who is this?
Institute of Medicine.
Where's that?
Well, it's part of the, let's see, Institute of Science or something like that.
It's when the federal government wants some kind of information about medicine in America, that's who they go to. Is this body of august
And they're
physicians.
the driving force for evidence-based medicine. And the American Academy of Neurology tries to follow what they say they're supposed to be doing. And the latest thing is that all of these studies are supposed to have input from consumers or patients or something to that.
They're the ones that are responsible for duty hour limitations.
For the what, Steve?
Duty hour limitations.
Okay, so they're bad guys.
Yeah, generally.
Pretty much so.
Black and white I can handle.
Yeah.
Oh. Well, we were just trying to lengthen our residence day by 1 hour for Journal Club, and we couldn't do it because of the time restrictions. And the fact that none of them are mentally set to do that much work.
There is a study going on now of comparing one group of residents with duty hour limitations to another group of residents without.
Really?
Yeah.
Is that something we can get in on?
It's at Vanderbilt, and I don't know what the endpoints are. I don't know what variables they're going to measure, but it should be real interesting.
You have to include accidental death in traffic at 6 a.m.
Well, yeah.
Well, I think Steve says, we've had residents who want to stay over here for some learning experience, but they can't because they've used up all their time.
Yeah.
Well,
They can stay an extra 4 hours.
Per what unit of time? Per day? Or
Well,
per week?
like if they work 24 hours, they can stay an extra 4 hours. But they can't be told that they have to do it. They have to do it voluntarily. And there are residencies that have extended duty hours, like neurosurgery. I don't know how this came about, but neurosurgery has duty hour limitations of 88 hours a week.
really?
Yeah.
Well, the hour is upon us, and I will go ahead and get started, expecting that some more will drift in as we go along. So I'll start slow and gradually pick up speed. So I think I know everyone in the room, but I'm Lee Archer with the department. And I'm going to talk about MS, and so we're supposed to say if we have any conflicts. So I'm not on any speaker bureaus. I'm not currently doing any research. I did participate in the phase 3 Tysabri trial. I do have a dog. I have a wife. I will talk about off-label use of medication. So that's pretty much everything I think you need to know. About 10 years ago, my wife planned a trip to Paris, and she said, "What do you want to see?" when you go to Paris. And being a good neurologist, I said, I want to see where Charcot's buried. And she said, who is Charcot, and why on earth would you want to go see where he's buried? And of course, Charcot, back in the latter part of the 1800s, separated MS from other diseases. I was reading last night, one of the things he focused on was the tremor, and distinguishing it from the Parkinsonian tremor. And then noted that the lesions in the brain were different. The people with Parkinson's disease a tremor at rest, didn't have the lesions in the brain. And the disease was primarily named after what he saw, these hard areas, these scars that were in the brain at the time. What do we want to talk about today? So I'm going to take a case-based approach, talk about adherence to medications and how we often have to help people with that because a lot of people don't want to stick with their medicines. Talk about how to deal with multiple symptoms in one patient. Talk about psychogenic problems because it seems like they're very often superimposed on MS patients. MS patients seem to have a predisposition to have associated psychological issues. I'm going to talk a little bit about PML when using Tysabri, and then about what to do when somebody's MS is uncontrolled, whether it's secondary progressive or primary progressive. So the first case, 37-year-old presented with numb feet for 3 weeks, about 6 months before, that gradually resolved. She's an administrator for an MRI facility, so she got a scan of her head fairly quickly in the onset of her symptoms. She had white matter lesions consistent with MS. Spinal fluid showed oligoclonal bands. Exam was normal, and she was put on Copaxone for 6 months. But she just didn't tolerate it because of the injection site reactions, and she was worried about the side effects of other medications, including the new oral drugs. And so we spent some time talking about that. And when I have people that tell me they don't want to take something, obviously we don't want to turn them off and say, well, I'll never see you again, unless you do what I say. I think most of us feel like that paternalistic approach is long gone with medicine. We want to be partners with patients. And so I talked to her about the other approved medications and told her, if you don't want to take something, at least let's follow you over time. And let's repeat your MRI. And if you have new symptoms or you have new spots on your MRI, then let's reconsider treating you. And so we've done that. Now we're lucky with MS, very lucky, that we have so many treatments now. I was raised and trained in an era when we had no treatment, and we even debated how aggressively to pursue the diagnosis because we said we would ruin somebody's chances of getting insurance or being able to keep a job if they carried that diagnosis. But now, of course, it's just the opposite. We fight hard to make the diagnosis because we have all these good treatment options now. Beta-seron, Copaxone, Avonex, Novantrone I'll talk a little bit more about later, although we don't use it much anymore because it is the most effective treatment we've got for MS now. Rebif, Tysabri, Extavia, which is a version of interferon beta-1b, Gilenya, Aubagio, and Tecfidera. And of course, we've got others in the pipeline coming along. She declined the other approved medications right now because of fear of side effects. But we said, let's meet again in 6 months. Let's repeat your MRI scan, and let's keep rethinking it. And I feel like she will want to take something later. Either she'll have new symptoms or she'll rethink it. So I'm quick to give people the information on the medications so they can review them and think about them more carefully at home. 52-year-old woman with MS for 6 years on Tysabri after she had failed 2 other agents. She's paraplegic, lives by herself, has aides that come to her house. She has muscle spasms that are intractable despite 3 different medications. She has trouble keeping her medication straight. Bladder spasms are severe despite anticholinergics. Depression remains a problem. And for good measure, she has eczema. So what do we do when somebody has a lot of different symptoms? Well, we try and do something similar to what is done in the ALS clinic. we see people at frequent intervals because we anticipate they need to see us to go over these problems fairly frequently. And then we want good communication. We want to make sure the family knows exactly what we've said. We encourage family members to come with them, and we communicate with the other doctors. And in this case, for sure, we needed to get the family's help to keep her medication straight, because that seemed to be a big part of her problems. And then I always encourage people to bring a list of their problems to the clinic so they don't forget what all we want to talk about, and a list of their medications. And in this case, we talked about a rehab medicine consult or a stay in an inpatient rehab center. As we went through her medications, we realized that she was not taking tizanidine. And so we emphasized that we needed to start back on that. And she did improve. I referred her to rehab medicine for consideration of a baclofen pump. I copied the notes to doctors I referred her to, including a dermatologist, ophthalmologist, urologist, and a rehab doctor. Family agreed to keep up with their medications and put them in a pill box. We wrote out detailed instructions for the family to put her medications in her pill box, and I set her return appointment back for just 1 month to make sure we were on the right track. Case 3 is a woman that had psychological contribution to her problems. She presented for the first time late last year with a history of MS, symptoms dating back to 2003, but she had been diagnosed in 2006. And she had been seeing another neurologist, and she had been hospitalized at least once a year for intravenous steroids. She always presented with more weakness in her legs. Other symptoms, though, have included memory problems, urinary urgency without incontinence, coordination problems with her arms. Brain MRI shows 4 white matter lesions, all smaller than 1 centimeter in size, that have not changed over time. I had her old and her more recent scans, and they've been stable over this time. Past medical history significant for asthma versus COPD. She said it just depends on what doctor I see as to what they call it, which I thought was a little unusual. Sleep apnea, hypertension. She had been on Copaxone since she was diagnosed, also taking clonazepam, Cymbalta, Provigil, oxybutynin, gabapentin, metoprolol, baclofen, and vitamin D. She's a school counselor. She enjoys her job, but she also had problems with physical and psychological abuse as a child. She had received counseling for 7 years, and she told me her father was an alcoholic. Review of systems was positive in virtually all categories, including depression. Spinal fluid had been normal in the past, and interestingly, and I'm not sure I have had this happen before, she brought with her the results of an MMPI. And that was so nice, and it had a classic conversion V pattern, like we often see with people that have a conversion tendency. Her exam had normal reflexes, cranial nerve sensation, give-way weakness on strength testing, but she was at least 4+ everywhere. Slightly wide base, shuffling gait. So I don't think anybody here would think that there could be anything except a large psychological component to her problems. We get that from the MRI scan. The MRI scan shows very minimal disease that hasn't changed over time. We get a hint from the history where she had a history of early childhood abuse. Father was an alcoholic, which predisposes people to stress-based problems later on. Her review of systems was positive for everything. And then her physical exam showed signs that we often see with a psychological component to her problems. So how do we approach that? I like to hit it head on. I like to go ahead and tell people, I think there's a stress component to your problems. It doesn't mean you couldn't have MS, but stress seems to be playing a role, and we have to recognize that. Stress can make MS worse, and it can create symptoms all by itself. And so I like to approach it from the positive standpoint. When Dr. Lucy was training me back in the covered wagon days, we emphasized what a good diagnosis this was, that we would much prefer to have this than to have some other more ominous disease. I'd much rather have a conversion reaction causing the symptoms than to have a flare-up of MS. And so I always emphasize this is a positive thing. And then I think some of the keys are to communicate closely with the other doctors, the primary care doctors, and I often copy my letter to the patient so that they know exactly what I'm saying. I'm not trying to hide anything from them. I'm trying to tell them the same thing that I'm telling their doctors. And that's what we did. I told her I thought she had a superimposed conversion reaction, and I didn't deny the possibility that she could have MS. She did have lesions in her brain, but they had been stable over time. And so we said we don't really need to change anything. And I pointed out there were features on her exam that went along with stress. There was a recent article showing that if you point out to patients the findings on the exam that go along with a stress-based component to their problems, that often that's a little easier for them to accept, that they have a little bit more acceptance of the stress playing a role with their problems. So we could continue the Copaxone. Thank goodness she was on the safest medicine that you can be on. Copaxone has basically no liver or renal toxicity. You don't have to check any lab work with it. So I was very glad that she was on a very safe medication if we weren't sure that she really needed to be on it. What about being fearful about PML in people on Tysabri? So 18-year-old woman with MS was started on Tysabri as initial therapy a year ago. She had symptoms of double vision, ataxia, and she had 6 enhancing lesions at the time we started her on medication. She also had numerous non-enhancing lesions. And so I felt like we needed to be aggressive from the start with her. She was young, she had very active disease, and so we did that. But a month ago, she started developing increasing fatigue and memory problems. Her exam was unchanged. Tysabri is extremely effective, 69%. Okay, good. I'm glad we got that back. Annualized relapse rate is decreased 69% compared to placebo. There's a 76% decrease in new or enlarging T2 lesions. There are virtually no cases of PML in the first year that the drug is used. And if you are negative for prior exposure to the JC virus on a JC virus antibody titer, the odds are essentially zero, less than 1 out of 10,000 that you'll develop PML. However, if your antibody titer is greater than 2, the odds of developing PML go up to around 1 out of 100. So we start thinking when that titer goes up about putting people on something else. So this was her scan, and she had a new lesion in the back here in her occipital lobe. And for an example of a PML, this is a more classic example of PML, kind of a ground glass appearance, several lesions that seem to have kind of started coalescing together in this case. So the concern was that this might be early PML. So she was tapped. It was negative for the JC virus. If we're suspicious, then we need to do that and go ahead and see if the PCR is positive for the JC virus. The patient was scared by all of this and asked to take something else. And so at the time of this, she wanted to switch to the safest medicine possible, and we did that with the caveat that we would continue to follow her closely and consider something stronger depending on her course in the future. Just a review of the clinical subtypes of MS, the way people typically present is relapsing remitting. That's 85% of people that present with MS, but it's only a prevalence of 55% because people convert over time. They convert to the relapsing progressive form. somewhere around 5% of people are benign, but we don't know who those are until some time has passed. So we can never make that judgment as they present. But I often tell people that so that they'll know they may have a benign type that's going to do well regardless of what I do, regardless of what I treat them with. Occasionally I'll see people who can tell me in my 20s I had optic neuritis. In my 30s I had transverse myelitis, and I recovered well from both of those. And now in my 40s I have some numbness in my left arm. And their scan may be typical for MS. And we'll debate whether or not to put them on treatment because they've had MS for 30 years. And it has seemed to be relatively benign. So there are a few people that I can say that when they present to me, but the vast majority, we assume that they're not benign. Another 5% have primary progressive MS. They just progress from the start. And this is the most frustrating type of MS because we don't have any FDA approved treatment for primary progressive MS, unfortunately. There are some trials, and so we start thinking about treatment trials in that group. Secondary progressive, 50% of people will change from relapsing remitting to secondary progressive within 10 years. 90% will change in 25 years. So here's a case of a patient with relapsing progressive MS. 19-year-old, African American, presented to me 3 years before with ataxia and fatigue and was diagnosed with MS. He couldn't tolerate Rebif and was placed on Avonex. After 6 months of Avonex, he had another exacerbation and was left with much more ataxia, and several enhancing lesions were seen on the MRI of his head. So we talked about other treatment options, including Tysabri versus Novantrone or cyclophosphamide. So far as for secondary progressive, Novantrone and Tysabri are FDA approved for that subtype. We do use some other things off-label. We'll use cyclophosphamide, methotrexate, pulse steroids. There's been a tendency to use cyclophosphamide a little more than Novantrone because Novantrone does have a high incidence of leukemia. About 1 out of 300 people develop leukemia with using Novantrone. Patients differ a lot in how much risk they're willing to accept. And as you go through your career, you'll appreciate just how variable that is. Some people want to take the strongest medication possible and will accept a fairly high risk, and others want to take no risk at all. I've had patients that were basically bedbound who said, I don't want to take a chemotherapy drug because of the risk of cancer. I'd rather be bedbound than accept that risk, even if it's a small risk that I might develop cancer. If patients are having more symptoms, then I often will, and I'm not sure how much more aggressive to be, the MRI scan obviously will influence me a lot. Novantrone, I've used a lot of Novantrone through the years, and I was disappointed when all the reports came out about the increased incidence of leukemia because it's such an effective drug. I put about half the patients I put on Novantrone went into remission, and I see some of these patients back yearly now because they're doing so well. They've never had problems since then after a course of Novantrone. And it's really the only drug that seems to do that. None of the other drugs seem to put people into remission. When you take them off their drug, they resume having exacerbations. Now, it can cause congestive heart failure, like the chemotherapy doxorubicin. So you do have to do an echocardiogram with it. As with other chemotherapy agents, nausea has to be blocked with medications. It can cause some hair loss, infertility in women, and you have to remember that they'll reach a nadir with their white cells about 10 to 14 days after the administration. Obviously, you have to follow the CBC and the liver functions. As I said, it does put people into remission, in my experience, about half the time or more. And this is the only study that I know of that at the end of the study, patients on average had an EDSS score that was better than when they started. So it was very impressive with their phase 3 trial. The exacerbation rate was substantially reduced with it. Tysabri, mouse-derived IgG monoclonal antibody to the alpha-4 integrin, which facilitates adhesion to the vascular epithelium. When that receptor is tied up, then the white blood cell can't stick to the side of the capillary and can't enter then the brain. So it's been available since 2006. It had been released earlier than that and then taken off the market when they discovered several people with PML. It is given monthly intravenously. 3 patients out of roughly 3,000 in the initial clinical trial developed PML. 2 died. The FDA mandated a tracking program. Now we stratify people as to how much their risk is based on the titer to the JC virus. And if the titer is greater than 2, typically we'll talk about taking them off. But we have a fellow in the hospital right now that we took off Tysabri just for this reason, who's had a rebound exacerbation that's incredibly severe with multiple enhancing lesions. And we had someone similar about 3 or 4 months ago. And so I'm rethinking the value of taking people off and reducing their chances for PML. Because in my hands so far, the experience hadn't been real good with switching people to other treatments. Somewhere around 1.7% will have a hypersensitivity reaction. And this is not a reaction that you can say, okay, well, we'll just try it again, see if it happens again. There are a lot of chemotherapy agents that the infusion center uses, excuse me, that the nurses nurse people along with reactions. And they give them Benadryl and steroids, but this is one you're not supposed to do that. If they've had a severe reaction, shortness of breath, rash, you're basically never supposed to use it again. The odds of an anaphylactic reaction go up if you try to use it again, if they've had that type of reaction. Somewhere around 6% of people develop antibodies to Tysabri. And so if somebody is doing poorly and you're equivocating whether or not to switch them to something else, that could help tip you one direction or the other as to whether or not to switch them. The annualized relapse rate is decreased substantially to by 69% compared to placebo. The impact is especially prominent on people that had a high disease burden on their MRI scan. 76% decrease in enlarging lesions. I use methotrexate off-label, and many of you have seen me do that. I started doing that before we had many options, and I still have some people on it. The dose is typically 7.5 to 20 milligram 1 day a week, and it's really pretty safe if you have not used it before. The odds of a significant liver toxicity or leukopenia are really quite low. We do check CBC and liver functions monthly the first 3 months and then every 3 months afterwards. But statistically, it's very safe. It has been shown to be effective in reducing disability in the upper extremities in studies that looked at both upper and lower extremity function. It reduces the MRI activity over Avonex alone when it's combined with Avonex. And so you'll still see me with a few patients on methotrexate for various reasons. So we opted for Tysabri. 2 years later, MRI scan is stable. He's taking Algebra 2. I think that's a good indicator you're doing okay if you can take Algebra 2 in high school. And looking forward to college. Still has some ataxia, fatigue, and needs a little extra time to complete exams, but functioning well. Case 6, primary progressive MS. 45-year-old woman presented late last year for a second opinion regarding treatment. Initial symptom of dystonic posturing of her right arm and leg, which is unusual with MS. Typically, you don't see dystonia with a presentation of multiple sclerosis. Led to MRI scans of her head, C-spine with a lesion seen at C6. Spinal fluid showed elevation in IgG index. Took Avonex for 7 years. Well, I'm sorry. She had started on, she had actually presented to someone else before. I saw her for the first time in August last year, but she had the history dating back substantially before that. So she took Avonex and then Copaxone, but continued to have progression. She had never had an acute exacerbation. Now she primarily complains of spastic gait, bladder control is mildly impaired, and another MS center had recommended she take azathioprine. Exam shows spastic paraplegia, bilateral extensor plantar responses. Unfortunately, this is a big problem in the MS world. It's what to do for primary progressive patients. No treatments have been found to be effective in any of the big trials. And most people say now immune suppression has failed to be effective in so many people that in general we try and avoid it in primary progressive. In one trial using rituximab, it did seem to be effective in primary progressive MS if they were younger patients and they had active disease on their MRI. And that kind of makes sense if somebody hasn't accumulated as much disability and they do have enhancing lesions, that they might be the ones that would benefit from more immune suppression. There are some hints in the literature that there's a subgroup that may also benefit from pulse steroids, and so I will do that on occasion. And she opted to do this. We gave her dexamethasone 1 day a month, and the residents have seen me do this a lot. Give people 96 milligram of dexamethasone, which is equivalent to 500 of solumedrol intravenously. And studies show you can get as much steroid into the system orally as you can intravenously. I do give them a proton pump inhibitor and usually a sleep aid to help them on the night after they take that. Of course, you'll have a few people that will have adverse reactions to it, but most people tolerate it very well. And we're considering referring her for a primary progressive trial. There was one study back in 2001 using methylprednisolone for 3 consecutive days every 3 months. But most people adjusted that and said it's a little easier to tolerate if you take it 1 day per month than 3 days every 3 months. And so most people will adopt that. Well, I finished early and should have had a couple more cases, but we have plenty of time for questions about MS. Let me turn on the light and see what questions you have.
So regarding this mentioned of multiple sclerosis, can you depend on the EDSS to start with to choose what kind of initial therapy you will have?
Do I use the EDSS to help guide what's the treatment decision? Typically, no. Typically, I don't. But you may see that, and third-party payers may use that as an excuse, and I put it that way, as an excuse not to fund certain medications. We see that already where because a drug may have been shown to be effective in a randomized controlled trial, insurance companies may not pay for it because it's not FDA approved for that indication. Typically, if it's an expensive drug, then they'll use that as a reason not to fund it. So we may see that where some third-party payers may say, well, the study only took people with these EDSS scores. Therefore, we're not going to pay for it unless they fit in that range. I've been known to fudge things a little bit, in order to fit the criteria, Paul.
If a patient's stable for years on one of these medicines, is it basically indefinite, or do you ever try withdrawing it?
So, good question. Should we try withdrawing in people that have done well? And when the interferons came out in the mid-90s, and we didn't have really much else into the mid-2000s, a lot of these people had needle fatigue and scarring, and they had trouble continuing with them. They just couldn't find a good place to inject. And several of them had been stable for 10 years. And so they came to me and said, look, I just can't inject anymore. We don't have another good option. Let's just try off of it. And so I took several of those people off, and over half of them had another exacerbation. And so at least with interferons and Copaxone, I said, I'm not going to take you off, or I'm going to find something else to put you on.
So lifelong unless they break through it.
Well, lifelong for pretty much everything except Novantrone.
Right.
Novantrone is lifetime limited anyway, but that's the one that seems to put people into remission. But basically all the others. And people ask me that question all the time. Is this lifelong? Am I going to be on this the rest of my life? And I tell them, you know, things have changed so much and just in the past 10 to 15 years. Who knows what's going to change in the next 5 to 10 years? We may have some cure. We may have a blood test that we can do to see who does need to stay on it or who needs to switch to something else. So I try not to tell them, yes, you're doomed forever, you know, to be on this drug. Well, who knows? You know, this is what we're going to use for now. And if you're uncontrolled, we're going to do something else. If you have side effects, we're going to do something else. Or if our knowledge increases and we find something better, then we'll switch it so that they don't have that feeling that, oh, I'm doomed forever, you know, to take this or that drug. Good question. Other questions, Steve?
Do we really know much more about the cause of MS than we did 30 years ago?
So the question is, do we know more about the cause of MS than we did 30 years ago? I guess really the answer is no, so far as knowing enough to really impact what we do. With virtually all these medications, there was not, you know, I guess you could say perhaps with the exception of Tysabri, the drugs weren't really designed as much as they were just tried, just empirically tried to treat MS. So the honest answer is no. We know, as you know, and just as a review for the residents, that you inherit a tendency. And if your mom or dad has MS, you have about a 5% chance. First-degree relatives have about a 5% chance. So there's an inherited factor. But then there's an environmental factor. But there's something about the environmental factor that it's not 100%. If you have the genetic factor and you have the environmental factor, it's not 100% success or 100% certain you're going to have MS. Because in identical twins in the same environment, there's only about a 40% chance that they will both have MS. So it's a complicated story, and we don't know the answer to it.
Can you talk a little bit about vitamin D?
And so Dr. Metzer asked about vitamin D and MS, and I'm glad to bring it up because vitamin D is so safe, unless you take mega doses of it on a regular basis, that everybody with MS should be on vitamin D, and their children should be on vitamin D. There's a lot of retrospective data showing that vitamin D may impact the occurrence of MS and also the frequency of exacerbations. There have been some nice retrospective studies where during the course of a drug trial, blood samples were archived. And some researchers have gone back and used those blood samples to measure the vitamin D levels. That was not a part of the study to begin with, but they went back and sampled all the blood samples for vitamin D, and then they said, let's see if there's a difference between those people that had exacerbations and those that didn't. And lo and behold, those people that had higher vitamin D levels were less likely to have an exacerbation. Now, this is a retrospective analysis, but it's pretty powerful when you are looking back without any foreknowledge of how you were going to group those patients together. I usually recommend 5,000 units daily, but you can always do the 50,000 units once a week. And endocrinologists, I think, like to do that, feel like it's absorbed better, it's more reliably taken. And it's relatively cheap to do it that way, too. Now, how does it help? We know that it is used by the immune system. The immune system seems to be more efficient if you have a high or good vitamin D level. But as to exactly how it impacts the immune system, we don't know.
What about the relationship that's been speculated about the relationship between vitamin D levels and sun exposure?
Mm-hmm.
We know that people who grow up in northern climates are more likely to get MS.
Mm-hmm.
And I've heard it speculated that that's because they don't get as much sun exposure.
So the question is, can we tie that to what we know about higher latitudes having an increased incidence of MS? And it may well be, because statistically it's true. Vitamin D levels do go up as you get closer to the equator. Average vitamin D levels in the population, average vitamin D levels go down as you go north. And that may well be the explanation for that gradation. The classic explanation was that the neurologists were smarter in the north, that they could diagnose us. Dr. Lucy told me this. That was actually published at one time.
They do get more money.
They do get more money. But it turns out that in Europe, the smart neurologists are in the northern part of Europe too, which kind of cast a little bit of doubt on it when somebody pointed that out.
So are vitamin D levels higher in all parts of the world as you approach the equator, or is that just true in the U.S.? Because, as you go further north, your summer days are actually much longer. Is it?
I don't know.
I mean,
I don't know the answer to that.
The winter days are certainly shorter, but your summer days actually have more sun exposure.
Mm-hmm.
Alaska flowers are enormous for a reason.
Yeah. It's a good question. It's a good point. I don't know the answer to that.
That may have to do with the amount of time the sun is overhead.
Yeah, I don't know.
Most people feel like the overall incidence of MS is increasing in our population, and one of the theories is we all use sunscreen now, and that maybe in general we have even less exposure to the sun than we did because everybody covers up with all the risk in the past 15, 20 years. I know when I was growing up, we never thought about that. We never thought about sun exposure as being a risk, and I got sunburned every summer, and it was almost a mark of respect, that you were out in the sun and you got sunburned and you got a deep tan. So we've changed a lot, and there is some speculation. Maybe with the advent of sunscreen, we inadvertently increase the incidence of MS.
Well, it has something to do with age too, doesn't it? What was the study where people who grew up or lived as children in a northern climate and then later migrated south, that their incidence of MS or the risk for MS was higher?
That was an Israeli study.
Yeah. So because so many people immigrated to Israel, there have been studies looking at where they spent the first 18 years of their life before moving, and those from the northern climates carried with them that higher risk. Those from southern climates carried with them a lower risk when they immigrated.
Lee, do you want to comment a little bit on the various subtypes? I mean, I was kind of excited about a paper that came out a number of years ago that really tried to subtype MS by the histopathologic picture, oligodendrocytes surviving or dying. Is there any work being done on that? I mean, is there a way of imaging, for example, oligos in vivo? Because otherwise you'd have to do a brain biopsy, which is a little aggressive.
I haven't seen anything with trying to correlate subtype with treatment, with the exception of NMO, neuromyelitis optica. And so there's abundant evidence now that immune suppression is the way to go, particularly rituximab with NMO.
Again, I mean, the ones with whiter and less hair among us, grew up with Divic's disease. It was supposed to be a subtype of MS.
Right.
So I think there's a lot more peeling off that's going to happen over time.
I think so. And
primary progressive for a totally different disease than relapsing remission.
And we see some people that, I see a number of people that only have coordination issues, and they have diffuse coordination issues, arms, nystagmus, and they don't have any strength problems, they don't have any sensory problems, they don't have any cognitive issues, and yet there's these subgroup of people, and you can see scattered lesions in their brain, but their symptoms are virtually limited to coordination. And so there's something about, yes, there are certainly subtypes that we just have yet to work out how that fits in, or how that should fit into a treatment picture.
Historically, there have been association data associating some specific viruses to the development of MS. Years ago, measles was pursued a lot, and then Epstein-Barr virus, but it's never led to any practical help as far as I know. If you take MS patients, they have a higher occurrence of antibodies to these viruses.
To certain viruses.
Yeah.
But maybe it's just because they have a more active immune system. And measles is pretty almost eradicated, yet MS isn't.
Mm-hmm.
Yeah, but I don't know if there's any recent data on that. It was years ago when measles was pursued.
HHV6 has been looked at, Epstein-Barr virus, and you're right. There's several viruses that have an increased prevalence in the MS population. Why? Don't know. And is that truly a trigger?
Of course, maybe it is because of a difference in their immunological system then.
One of the tantalizing historical bits of information were the Faroe Islands, am I pronouncing that right? During World War II, they were occupied, and it was after World War II that MS became a part of their population. Up to that point in time, no one in that group of islands had multiple sclerosis, indicating probably there was a viral component, probably there's an infectious component that was introduced into that
They
population.
tried to blame it on dogs, didn't they?
Dogs?
Yeah.
I didn't know that.
Yeah, because the
The
military.
British soldiers brought dogs with them, canine distemper virus. One other question. Nancy Newman and Paul Phillips had a very interesting paper looking at the severity of disease in African Americans, stuff like that, and I think that's a well-established fact. So would someone's ethnic background push you towards more aggressive treatment if it's known that the disease is more severe in that group?
It's a very good point, and so the question is, does somebody's ethnicity influence how aggressive we are? And it does. If somebody's African American and they're uncontrolled, I'm going to move faster to put them on a stronger medication.
Is the incidence different, or is it just disease severity?
The incidence is basically the same, but the severity tends to be worse.
And if you're dark-skinned, you don't absorb vitamin D well.
Yeah, that's true.
Yeah.
That's true. And then it tends to be more severe in men, although the incidence is less in men. It tends to be more severe in men. So an African American man, I'm especially aggressive with. Well, I think we've used our time pretty well. Thank you very much.
Oh, and faculty, in case anybody didn't get the follow-up email, are
2 months ago.
Yes.
Someone else did. I don't know. I didn't know. I didn't give it to you. I didn't. Kind of
I applied to the publications committee.
What was their rationale?
There were enough paper, and they don't.
Stacy, could you find anything?
I sent it to you.
Huh?
I sent you the link.
Oh, you sent it to them?
It didn't really look into the. What would be the rationale for not letting the information out? Clearly they reversed it because they couldn't publish it. There's always trouble with I'll find it. It's an archive. I'll find it for you. I'll forward it to you. this is just, and that's, I mean, I'm glad that finding, because the original papers just gave a whole list, and they didn't find it. I didn't look for the African Americans. No significant, So you looked at it, and I was happy that you could learn the and I never heard anything about it. And then but yeah, I think it's very upsetting, especially if they now. Remember, I called Nancy and I told her that I actually called that afternoon. And I called that afternoon.
Yeah, I had a couple of.
B12 deficiency is a loaded diagnosis. I've seen patients go out. If they're not treated fast enough, you don't. Yeah, I'm gonna try to come to you. I hope you're doing well.
Yeah, I am. Thanks so much.
Okay, here it is. It was published by
Lead genetic data hasn't provided any guidance.
Association rate that with visual outcomes in pseudotic neuritis,
gene that is
and analysis of the
closest,
LPT. And this was just came out. It was
the receptor for interleukin.
Anyway, the
people that have tried to go, there's actually a
race
drug.
that this seems to be associated with contribution sensitivity, including outflows and affected eyes following trials. To my knowledge, this is the largest cohort.
Why would that
This is
be
even
the closest?
and represents
High
the first
hopes
evidence
when that study was done.
prospective data for the hypothesis of race
But I haven't seen it pan out so far.
It did worse.
You didn't.
So yeah, I
presume that falls.
think the fact that you did it 14 years ago.
Yeah, there was a study done in Italy, actually, you may have seen it, where they found in a blinded fashion, they could find no difference between MS patients and the general population with the venous ultrasound.
We invited him to paper, speak at the
Yeah.
Well, you gave a grand show on that one, didn't
It's still a strong debate because
Sure.
Went to the meeting.
I have a patient that went to Florida and had a stent put in. And then when I started following her, she had a clot. She had clotted it off. So first what she wanted was somebody to go in and remove the clot and open it up again. Because this is the reason she's worse, because she's got a clot. Where they put a stent in.
That is always
She did not have any symptoms.
I'm sorry.
And
I was looking at your painting up there.
So, thank you, John. So we're going to make a start.
Yeah, I have all that.
I hope you're doing well.
did you ever email it? Committee. So you submitted this project.
I was looking at your painting, I didn't see a signature.
Well, she is now going to paint the governor. Did y'all see that?
I can't remember.
Oviedo, she's been chosen.
Oviedo who?
Goolsby. Lives
Well, I actually contacted her about it.
I mean, I could have.
Well, no, I wouldn't do it. I would just thought I would appeal the.
Now she
I would
changed her
appeal
mind.
the committee and just talk to people and say, look,
I
this
guess
is
that's-
crazy.
Yeah, I didn't do that.
I've never heard of this, you know, but the market,
Yeah.
study is a study.
And
I guess they waited 16 years into that.
Put varnish.
I mean, I'm just going to ask Nancy, curiosity what happened.
Still-
I remember giving her the email. I'm going to say,
I
how did we
think-
get this email 16
I've never
years
seen
ago?
anything
And then we're told not to
comparable to
publish
her
it. Someone
work.
else
If you
16
look
years
at
later
the
published it. Makes no sense.
Well,
Anyway, for what it's worth, you were
And actually,
right.
I don't think that I had all the contrast sensitivity data.
No, true.
Because I had the rough data, I went through and got all the
And he
the
has a
acuities and
Yeah,
the
so they
ADS
could
and
give
the
me
professor
I'm
there.
pretty sure they did.
Yeah.
They give me
Looks like
Oh,
a
they
medical
did,
professor.
and I spent a lot of time going through it. I still have this shit.
Yeah.
About
Well,
100
I-
years
I-
later,
I-
there's a guy named Dawkins in
What
Philadelphia.
they
He
did,
did
they
a
said to you, we're
professor
not going to publish.
buried behind
After I did all the work.
Yeah, they knew you were out.
Because I asked for the data and I was given permission, and I went down to Tampa.
Now, Lee, I hope you do something with, for fun on your vacation. Marshall takes a vacation so he can catch up with his work.
All right, what is?
Well, I came into this, but I'm gonna do some other things this afternoon. This was one of my vacation days, but I forgot I had grand rounds, and so I just went ahead.
I'm glad you did.
Yeah, it worked out okay.
Yeah, absolutely, they can come with ACH or
Well,
the
unfortunately, it
Monday
is so
morning I'm at ACH.
complicated that the general
I'll be
neurologist
some of those.
can hardly afford to keep up
That's the best
with
one.
the evolution of treatment.
Monday morning and all day Monday.
I presume
All day Monday.
Kathy's keeping
That's a
that
good time
pretty
for them to
well.
come.
And she has.
Tuesday surgery.
She
Wednesday
sees a good
morning.
number of patients, and
But a lot of that'll be.
and she has an
Yeah, but a
infusion
lot of
center
that'll be post
for Tysabri.
Not all.
Well,
A lot of it'll be
well,
post
actually, for
half a
any
day.
neurologist,
The next best
just seeing
time
MS patients,
is
you're a boon
it's actually probably
to
Friday
the
all day.
neuroradiologist,
Friday from
but
9
you
to
don't make
about
much
1 or 9 to 2.
Well, that's
I'm
it.
here.
I think if they
They
run
can
their own
see the
infusion
more
center,
in
that'll
the
make
space.
it.
yes, yes.
So I'm here. Well, Thursday
And
it
did
gets
y'all read
complicated.
Kathy's,
Every other Thursday, I
Editorial.
alternate
yeah,
surgery
whatever.
with clinic at ACH.
It was in the
So every
paper,
other
she was
Thursday
talking
morning.
about Obamacare.
I thought it was very well written. Drug. I didn't, I was reading it and
They
then
can
got
come,
down to
yes, they
saying
can
she
come in
was
a
a
Thursday
neurologist.
morning
That's the
if
first time I
it's not
looked
a
at
surgical
it.
Yeah.
or Thursday afternoon at the med center. If it's
I'm gonna
just-
speak to these reps back there in your office. I'm sorry.
Okay, sounds good.
I would,
Okay.
you're setting up the rotation for the residents, correct? I think it should be mandatory, not elective.
Yeah.
Is it a mandatory already? I think it should be mandatory.
There you go.
And I'm just not here to fight. If I were here, Chaco's fight. But Nancy Newman, who I trained with, she made it mandatory 3 months for all neurology and all neurosurgery. 3 months.
It depends on the ACJ, what they require from you. They require, they don't like specific electives, we ask our residents to do it. We ask them to do whatever they'd like to do.
Yeah,
We give them lots of options, and usually they take it.
Yeah, don't put elective, put it mandatory.
We'll do that.
That's what they
I
did
ask them
in,
to do
I will
it.
tell you,
Yeah.
the president, the chairman at Emory of neurology, who was a world-renowned in sarcoidosis at the time, this is 96, could not look at a disc. Clearly, he could not see it at all, at all. So Nancy's, I just have not picked up this battle because I'm not here, and I do a lot of strabismus. It's really Chaco's battle, but she fought with the idea that neurosurgeons and neurologists need. She got 3 months. I don't think most places get that, but she made the neurosurgeons go there. They didn't like it.
1 month a year, right?
No, 3 months rotation, I think, for the whole residency. She got them for 3 months straight for the whole residency. That's the way she did it. Now, the neurosurgeons didn't like it because they weren't operating. But do you know
Thank
anything?
you. Thank you, appreciate it. Good, I'm glad you did. I hope you have fun.
Oh, can you do me a favor? Well, she's a very strong personality. She trained me. She's very good. She's spectacular. She's a neuro-ophthalmologist. She trained at Mass General for neurology. She's a neurology-trained neuro-ophthalmologist. She is coming here to speak on December 18th. Can you transmit? I'll get it to your residents and faculty.
Sure. December 18th.
Yeah. It'll be a Thursday.
Mm-hmm.
For the ophthalmology, she's going to talk to the residents from 3 to 5,
Mm-hmm.
grand rounds from 5 to 6. For the ophthalmology residents, we're canceling clinics. I would recommend, it's up to you what you do it's up to you the whole thing. But I would get everyone there you can.
Okay. 3 to 5 talking to residents about.
We don't know yet. It'll be neuro-ophthalmology. Of course, it'll be neuro-ophthalmology. It'll be relevant.
Okay. Yeah. I'll make sure. We don't have anything on Thursday afternoon.
Well, I would hit 3 to 5 and 5 to 6. And I'll also, if you can, I'll tell your faculty, but distribute it to your faculty
I'll
too.
tell Dr. Beatty and I'll tell Dr. Zahara about it too.
Yeah.
Okay. And it will be
Nancy
great.
J. Newman,
Yeah.
from memory.
And one last thing, in ACA, in university here, when we're doing neuro-ophthalmology, we're just
Yeah.
rotating with Dr. Chaco. I don't know exactly what his schedule is. It's because sometimes this is what happened with me. I accidentally knew about user.
Right.
So, because I was going to Epic, that's how
Yeah.
I ended up in ACH. So, and Dr. Chaco was on vacation.
Yes, you got me.
So, whenever sometimes Dr. Chaco is not available,
Yeah.
so the residents are not doing anything. Can they come with you?
Well, yeah, but now this is important though. Email me and let me know what's going on.
Okay.
So I don't want them to show, I mean,
Sure.
I would
just don't
prefer they
want
not
to
just
be-
show up by random.
Yeah.
Well, and the other thing is what I would prefer is that when you do that rotation, we ahead of time figure out time with Chaco and time with me for all of them.
Yeah.
And not just do my clinic when he's not here.
Yeah. that is
So
what
I would say if you let me know who's coming and when, Joe and I will figure it out.
Okay, I'll send you now the name of the residents who are coming.
Okay. Let me know the rotation.
They
Let
might
me
be
know when
rotating, yeah.
and what days.
Okay. Okay.
And Joe and I will figure it out.
Okay. Sure. I'll see you.
So of course, when he's away, they'll come with me. When I'm away, they'll go with
Sure.
him.
Sure.
But I
Yeah.
think even if we're both here, we should
Mhm.
work with some division.
Sure. Sure.
But
Sure.
if we plan it,
Mm-hmm.
I can get the most neuro-ophthalmology for when they come.
Yeah.
If we don't plan it, like if they come on a post-op strabismus day, they can always learn something, but it won't be as valuable.
Yeah. Yeah.
So if you let me know what days, I will
Sure.
put it the days
Sure,
where I see
sure.
because to make it more complicated, every other Thursday
Mhm.
I switch strabismus with neuro. So you're gonna have to just if you give me the schedule, we'll get them in the right place.
Sure, sure. And I'll send you the possible dates for the conference if it's okay with you to give us some lectures.
Yeah, absolutely.
Okay.
Absolutely. You got my cell too?
Yes.
Yeah. Call and email
Sure,
and
sure,
if I don't,
sure.
if for some reason, I'm swamped and if for some reason the week goes by you haven't heard, email me again. I won't.
Sure.
I won't. Just make yourself known.
Okay. I'll do
Probably that. My schedule. The problem. I'm happy. I like doing this, so I will get it done.
Yeah.
But with the med center and the financial issues, they are so aggressive about the schedule that I have to put a lot of effort to block a time. I'll do it.
Yeah.
I'll do it, but it's just not as easy.
The same thing is with the elective with us. They're saying, for example, if anyone is in elective in neurology means a university, because they're paying the money. Because if you're on university, you cannot go to ACH. You cannot go. I just last year.
I don't. But the difference between you're here for educational purposes
They
too.
don't take that. They don't take that.
Well, that's crazy.
I know. The GME office does not take that. The VA says when you're in the VA, you get your salary. If you're not in the VA, you don't get your salary. The contract with the VA, there are some issues that the VA funds for inpatient rotations, clinic rotations,
Yeah.
not electives. So it's all funding. I know it's crazy.
Yeah, I
It
know
doesn't
it's
make
all
sense.
fun. Well, the VA is very bureaucratic,
Yeah.
but between the med center and children's, it should not be that rigid. And that's a fight for your
We had, for
chairman.
example, another case this year, a resident who missed one of her rotations in ACH. We have to go 3 years,
Yeah.
3 months. So we had to take off a resident from his current rotation to just make 12 months of ACH rotation because they don't fund 13 months.
Yeah.
And it's insane.
Yeah, it's
but,
crazy. That's crazy.
They said, no, we don't fund it. It's just funding thing.
Yeah.
Just paying the salary.
Yeah. Well, what they're doing, what they're doing with a lot of the attendings is they're trying to fill up their schedule. So if there's an opening, they want to fill it up without asking you, even if it's not your subspecialty. Now I fought that pretty well, but anyway, that's. Let me know, I'll block the time.
Sure. Thanks a lot, sir.
And on top of that, I'm also booked 3 to 6 months in advance. So anytime I want to move people, that's a headache. But I will find a time for the grand rounds and let me know the rotations, and we'll get the residents to have a good experience. Let's go.